share some of my knowledge and experience on the topic of falls and the management of falls in Parkinson's disease. I'm not used to giving a presentation where I can't see the individuals I'm presenting to, so this is a different format for me. I'll speak first and then look forward to taking your questions at the end. And please signal to Caitlin through the message board if I'm not speaking loud enough, and I'll adjust accordingly. So the objectives for today's webinar will be to have a better understanding about what are some of the risk factors for falls for individuals who live with Parkinson's disease, or often referred to as PD, what changes we often see with regards to their walking, to understand what this phenomenon of freezing of gait is and what contributes to it or can contribute to it, as well as overall strategies and recommendations to reduce the risk of falls. Every year, a third of seniors will have a fall at home, and that's just in the general population. People who live with Parkinson's are at a greater risk for falls for reasons that I'll talk about today. About 70% of people with Parkinson's will fall at least once a year, and 50% will have 2 or more falls over the course of a year, and about 30% of those will wind up needing to seek medical evaluation due to a more significant injury, such as could be a broken bone like a hip or an arm, some sort of trauma to their head as in a concussion, or significant laceration. So falls are a very big deal. We know they pose a significant health risk. There can be potentially loss of mobility and the loss of ability to live independently after a fall. And in my physiotherapy practice, I frequently, my first interaction with someone is after they've had a fall or a series of falls. And with many individuals, after they have experienced a fall, there is a fear of falling that develops. People often will start to restrict their activities. They, decline invitations to have social outings, so they don't go out as much. They spend more time sitting, which in turn leads to, an overall decrease in their mobility, and ultimately that increases their risk of falling again. So it really is a vicious circle, and one that needs to be addressed early if it's a problem. Risk factors for falls are complex, and there can be many. Some of the big ones that we see in people who live with Parkinson's disease are postural instability, which I'll speak further about, these walking changes related to walking, changes in people's posture, freezing of gait, which again I'll elaborate on, and things in the environment can be a risk factor. If people were, walking and needing to make a turn and lose their balance, because turning can be a problem for people with Parkinson's sometimes, trying to do more than one thing at a time, so what we refer to as dual tasking or multitasking is a problem for many, as well as something called orthostatic hypotension, which is a drop in one's blood pressure when they're changing positions, so that they, experience lightheadedness, they feel dizzy, they feel like they might black out. So that is also a significant risk factor for many. Postural instability. So this is an abnormal balance reaction that's seen more in advanced stages of the disease, and it's this tendency for people to fall backwards. The doctor that you see, or perhaps a clinician that you work with, will test this by standing behind you, and they kind of give you a quick hard pull on your shoulders to see if you can catch yourself and not fall backwards. So that's what they're testing. They're testing postural instability. And when people experience this, it can be more challenging, sometimes trying to stand up from a chair even, because of this tendency to fall backwards. And certainly when you're trying to walk, if much of your weight is in your heels, it can be much more difficult to move forward and to keep moving, and that increases the risk of falling. Some changes that we see with regards to walking in Parkinson's, So early to more mid stages of the condition, we see an overall slower walking speed. Often we see less arm swing. That might be in both arms or just one arm initially, that just the person just doesn't swing their arm when they're walking. And an overall kind of shorter stride, smaller steps, and just some shuffling can start in the, like I say, early to mid stages of Parkinson's. When we're looking at more advanced years with the condition, we're typically referring to someone who's lived with the disease for perhaps 10 or 15 years or beyond, because certainly there are individuals who live with Parkinson's for more than 20 years. But some of the changes that we see in regards to walking are more of a shuffling type of walking pattern, where the steps are very short and there's a lot of them. There's something called gait festination, and that is seen as short, really rapid steps that become smaller and smaller and faster. And this is, of course, a significant fall risk because someone can easily lose their balance. And then this, again, freezing of gait that we're going to talk further about, that is sudden and unpredictable blocks in the brain, which prevent people from moving, which I'll discuss further. So those are some of the things we see often once someone's been living with the condition for a long time. We're going to talk about posture. Posture, it's the foundation for all movement, so it makes sense that if people have changes to their posture, it will affect their balance and their ability to walk, putting them at greater risk for having a fall. And people, I say to people, you should really, you should not ignore early postural changes, nor should you think there is nothing that can be done about them. Some people with PD have perceptual challenges, meaning they perceive themselves as standing straight, but they are actually bent forward and or frequently leaning to one side. So some common things that we see with posture is a stooped posture. So the head is more forward, the trunk is more forward. There can be an asymmetry to one's posture, so they might kind of lean to the right or they might lean to the left. And there's also a general stiffness or rigidity. Some people have trouble turning their head from side to side or twisting their trunk from side to side. So those are some common things that we see. And improving posture certainly takes constant practice, and I say that for the general population. Certainly not just the case with people living with Parkinson's, but it's really even more the case if you have PD, because you have to be constantly reminding yourself to check in. And I frequently have people sit or stand in front of a mirror to get visual feedback on their posture. I'll encourage people to stand against a wall so they can feel what it's like to be standing tall, because many have problems with what we call body awareness. They don't feel their bodies the same way, and they don't realize, for example, that they actually are leaning over to one side. So they need cues in their environment to tell them that they do need to make a correction, so that they can have that kind of what I call a bit of a posture reset and give them a chance to correct. So I encourage people to use various cues. It might be a sticker on the mirror in the bathroom to kind of prompt you to check in with your posture and stand up a bit taller. It might be a sticker, a little reminder at your computer workstation. It might be in the rear view mirror of the car to sit taller in the car, or if you're in the passenger seat, can you check in with your posture and sit up? So there's many different types of cues that people can use, and sometimes, you know, if people have partners and spouses, that sometimes they have little secret signals between them. If they're out somewhere and the person is kind of really leaning, that person gives them a little bit of a signal to say, you gotta, can you stretch up a bit taller and straighten up. And I also want to mention the use of walking poles, because they're extremely beneficial for improving one's posture and walking ability, which in turn decreases fall risk. The poles force us to really stand up straighter, to swing our arms more, and we know from research that you're using the muscles in your trunk, so your core muscles, significantly more when you're walking with poles compared to walking without poles. And that, of course, is good for everyone, whether you have PD or not. And this can be a really nice activity for couples to do together, in that both will benefit. I'll mention that pole walking would not be recommended for anyone who has severe balance issues and needs a more stable walking support. So if there's ever, any question whether someone would be safe to use poles, I certainly would recommend that you get a proper assessment to determine which walking aid would be best for you. So we're going to move on to freezing of gait. And I want to spend a fair chunk of time talking about it, because it is the main reason why people with Parkinson's disease fall. It is this brief, sudden stop in either in starting to walk or kind of continuing to walk. People talk about, my feet, they're stuck to the floor. I feel as if I have heavy weights on my shoulders and I can't move. It is something we, again, tend to see later in the disease. But again, everyone is different, and not everyone will experience freezing episodes either. But it is something that we again, tend to see later in the disease process. And normally walking is an automatic event in our brain. We don't have to think about it, it just happens. But with Parkinson's disease, the brain center that controls automatic movements, like walking, is affected. And that results in this loss of what we call automaticity of walking. So people really then have to pay attention and focus on what they want their legs and feet to do, because it is not automatic anymore. So I'd like to introduce you to Wally, and Wally reached out to me a couple of years ago regarding his challenges with freezing of gait. He would frequently freeze in his home, moving about, as well as when he's out in the community. So I'm going to show a video of Wally, and this is an example of a freezing episode, and then we can chat about it. Let me try that again. So again, this sudden stop in movement. So so freezing a gait. It can often occur, like in this case that we just watched with the video, when someone is approaching a destination. So, he was approaching doors. It might be a chair for someone. The elevator can be a challenge for people, walking up to an escalator I've seen. It can happen often when people are looking to change direction. So they're turning because they want to go right or left. Or even just starting to walk, people can freeze. It also can happen if people are trying to walk through, say, a narrower space. So if you're in a restaurant and you have to pass between two tables, that might, be a trigger for someone for a freezing episode. And it can be precipitated, again, and exacerbated by many things. Anxiety certainly being one of them, the pressure of time, I need to get to that appointment, trying to do too many things at once and overloading the brain with that demand for attention. So you really need to try and simplify situations when possible. Crowds can be very challenging for people who experience a lot of freezing episodes just because they're really trying to focus on moving their legs and walking because it's not automatic. Plus, they're trying to navigate where they're going and their environment. And if there's someone talking to them, that could make it worse. And there would be lots of stimulation being in a crowd as well. So, I mean, it's just, these are just things that people need to, I think, maybe understand better that can make freezing worse. It doesn't mean you don't go out and do things, but just being mindful of what might make freezing episodes worse. So in terms of managing freezing of gait, there, like I say, there is no one size or one strategy fits all. It's a very, very complex phenomenon in the brain, and it's certainly not completely understood either. But there are things that people can try and recommendations to try and, again, decrease the frequencies, decrease the severity. So one thing, again, is avoiding multitasking. If there is challenges around anxiety and stressing about certain things, I know I had one gentleman, he would get very stressed out about going to his son's house because he would often freeze every time he wanted to go onto the back deck, and it was very anxiety provoking for him. So, you know, coming up with strategies on how he still could enjoy that visit and have it with less stress. But certainly if anxiety is part of something that you're struggling with your Parkinson's, having treatment around that can also help your freezing often. And again, avoiding pressure of time. If you have appointments, which many people obviously do, give yourself lots of time to get there. How you set up your home, you know, there could be things to consider. Removing obstacles if they're in walkways to make the space more open. And a treadmill walking has been shown to improve people's walking ability off the treadmill in terms of lessening the freezing episodes. And again, it's about trying to train automaticity in the brain. So that can be an option for some people. And certainly if you've never been on a treadmill before, but you're thinking you might try it, I'd make sure that you're safe to do so. And there's a lot of very interesting and preliminary research being done about spinal cord stimulation, actually, out of London, Ontario, to help people with freezing of gait. So that's really exciting. I want to talk about when someone is actually in the middle and, you know, is having a freezing episode, things that they can try in the moment. So we call this anti-freeze. So the first thing is to stop trying to move at all. The tendency is for people to try to keep moving their feet with the hopes that they're going to get going eventually, and that can often just make it worse. So as soon as you essentially are stuck, stop trying to move at all and just pause and allow your brain to reset. Then second, stand as tall as you can, stand as straight as you can, lift your head up, shoulders back. Then the third thing is, can you start to just shift your weight a bit from one foot to the other, one leg to the other, just not trying to move or step, but just shifting your weight. And then the fourth thing is to take a step. And so we're going to talk then about these would be some stepping strategies that you can try in the moment. So one thing that I frequently instruct people in is what call a half step, or some people can relate to it better when I say a wedding march type of step. So that idea that you're taking a step and then you're pausing and bringing your feet together. You're taking a step and pausing and bringing your feet together in a nice, slow and controlled manner. Or attempting to take a deliberate and a very large step can help people kind of get going again. So if you think about a drum major really driving your your thigh up high and bringing your knee right up. That can get people moving again. Trying to take a step backwards or either sideways can be helpful, and then trying to go forwards in terms of getting people to kind of get out of their freezing episode. So all of these strategies can be used like in the moment when people are stuck, but then of course these are things that I would practice with people when they're not frozen, just as a stepping exercise. So some further ideas on things to try when you're frozen is some sort of auditory cue. Some people will count, some people might try a metronome, so to hear that tick, tick, tick can help the brain to focus on something, and then you can get your feet moving again. There's certainly, an app you can put on your phone if you're a cell phone user for a metronome. Singing works for some people, humming. You want to engage the brain in a different way so you can get the feet going. Even a visual cue on the floor. So having a flashlight and shining a light in front of you, that can give the brain something to focus on to allow it to step. Stepping over a line on the floor if there's a pattern in tile, kind of focusing on one line and say, okay, I'm going to step over that line. There's certainly various laser, there's canes out now that will emit a laser kind of across the floor to help people, again, get this visual cue to help them keep moving. So I'm going to show a video here. So this is Wally, and he's working on what I mentioned as a half step, or this kind of idea of a wedding march. So trying to take a slow, big step, bringing the feet together, and you're trying to you're trying to break the habitual pattern of fast, and just show that one more time, trying to break the pattern of kind of fast, quick steps that freezing often what you're going to see with something that's, again, the opposite. And I'll even encourage people, if they have an area of their house that they tend to freeze, actually practicing this technique, going, say, from room to room. If there's an area someone says, I always struggle going from the kitchen into the bedroom, or this is something that people can try. Just to touch on orthostatic hypotension. So certainly, medications can be needed to help manage this. So that's something to address with your physicians, making sure that you have adequate hydration. For some people, they need to increase their salt intake. Something I teach as a therapist when I'm working with people who do experience these changes in blood pressure that makes them dizzy and feeling lightheaded is that can you pause twice when you are changing positions? So an example will be you're getting out of bed in the morning, or say you've had a nap. You sit at the side of the bed for 10 seconds, 10 to 15 seconds. And then when you stand up, you pause again a second time for 10 to 15 seconds. And this is just to allow, hopefully, your blood pressure to stabilize a bit better. And so maybe decreasing the amount of dizziness or lightheadedness you feel. Some people need to use compression socks or wear an abdominal binder to, again, help regulate their blood pressure during the day. So those are just some quick ideas around orthostatic hypotension. A couple comments about medications. Certainly, Parkinson's medications are utilized to maximize, the quality of your life, so you're able to participate fully or more fully in things you want to do. That synthetic dopamine that you take, hopefully, it's helping you to move and feel better, and thereby allowing you to exercise better. So dopamine has many important functions, including all the movement regulation, but it motivates us to do things. It increases our willingness to work for a reward. as well as it helps with mood regulation. So it's really, really important. And because it is so important, it's imperative that you're taking your medication properly. So when I visit people in their homes, I see a lot of variability how they're taking their medication. And, you know, that's certainly through no fault of the individual person, unless they just kind of aren't interested in taking it. But I do see a lot of miscommunication in terms of how people are being given education on how they should be taking their medication, whether you're taking Sinemet or Prolopa or Stalevo. And certainly don't compare how much medication you're taking to someone else, because no two people with this condition are the same. But you really need to take this medication on an empty stomach when possible. So 1 hour before a meal or 2 hours after a meal with a full glass of water. You want to achieve maximum benefit from this oral medication, and you don't want it to interfere. You don't want to interfere with its absorption, because this medication has to pass through your stomach and get into the small bowel where it's absorbed. And from there, it's taken into your bloodstream and it's pushed up to your brain. And that's where it's then converted to dopamine. So it has quite a long road to travel, and taking it with food, particularly any protein-rich food, can really interfere with its absorption, and then ultimately, you know, affecting how effective it might be for you. So just give it its best chance, and obviously speak to your pharmacist if you have any questions about this. But these are essentially the instructions I hear from the neurologist in terms of how you should be taking this medication. So the way we as therapists are managing Parkinson's with respect to prescribing exercises and educating people about the importance of physical activity is changing. And I see it slowly catching on in the medical community as well, because we know from research that those who exercise regularly will have better management of their symptoms and do better in the long term. Exercise has a protective effect on the brain. It can slow disease progression and motor deterioration in some cases. And people really need to think about exercise like one of their drugs, one of their medications, and they need to take it every day, pretty much. And that's okay to take it in small doses if you can't work for longer periods. You know, 10-minute chunks is fine, but it's that important. And I have seen people in my practice who reach out after they have been away on vacation. I had one gentleman who spent, several weeks at his cottage and really didn't do anything while he was there. And, you know, there was nothing else different in terms of medications, but just that lack of physical activity, he really noticed a huge deterioration. So it's really important. And in terms of, I think people hopefully are hearing from their medical professionals when they're diagnosed that you really should start looking at strategies around exercise and seeking out education on what people can be doing for themselves, and it should continue for life. We recommend 30 to 60 minutes a day, 5 times a week, and that's kind of the minimum. And it can sound like a lot, but again, it can be broken into small 10-minute chunks. It doesn't need to be an hour at a time. And there's no question that more is better with this group of people. More is definitely better. So, I mean, all different types of exercise, right, are good to be kind of having in your, we'll say, exercise toolkit. You want to have different types of exercise and activities in there. So one would be aerobic exercise. So it might be walking. It might be walking using poles, riding your bike, as well as things like functional movements, what I call practicing stepping in different directions, reaching, because certainly with Parkinson's, it's not all just about walking in the legs, right? People will feel stiffer in their upper body, struggling to reach their arms as much, harder to maybe dress, get a coat on, practicing things like standing up, practicing making turns where you have to shift your weight from one leg to another. That's a really important piece of functional movement. Thinking about balance, thinking about strength. We mentioned posture, and as well as some flexibility. So these are all good and key components of a comprehensive exercise program. This is a scale, so it's called the Rate of Perceived Exertion Scale. And I like just people to be aware that if something is really easy when you're doing it, it's not changing you. It has to be challenging to you, or it will not change you. So I tell people on this scale, you need to be working, somewhere between a 6 and an 8, somewhere in there when you're doing, saying, maybe you're going to ride a stationary bike for 10 minutes. I want it to be difficult. I want it to be hard, because that's going to have the biggest benefit for you. And that is what's going to actually change your brain in a positive way. I'm going to show a series of more videos here. So this is a gentleman who's 84 who reached out to me after having several falls. He just found he was having trouble picking up his feet. He was catching his toe on the side of the bed. He fell backwards a couple times. And yeah, so we're working on various stepping strategies and always thinking about trying to make movements big and exaggerated, because the tendency with Parkinson's is that it's harder to generate force with movement, and everything gets smaller and slower often. So we really exaggerate movements and then see a more normal movement pattern, say when someone isn't practicing. So if you practice the movements really big, then when you need to just be walking, say through a restaurant, your walking is actually appearing more normal. So again, this man can easily lift his knees up quite high, but yet when he was walking with his walker, he was really dragging and shuffling his feet. So again, it's about being really focusing in on what you're doing at the time and drawing attention to each and every step. So in here, again, this idea of being able to weight shift, so going from leg to leg, is very important when it comes to decreasing fall risk. So you can practice weight shift in many different positions. Standing, of course, as you're seeing here, I can get people weight shifting and sitting if standing is too hard for them to start with. But shifting from side to side, making it hard, using the arms in this case to stretch out, and having a target on the wall. Can you reach all the way there? Pushing him where he's almost feeling, he's having to work and feeling a little bit uncomfortable. He's unchallenged, but I mean, he's obviously in a safe place, and he's exercising in a safe way. I certainly don't encourage everyone to all of a sudden start practicing this in the middle of their living room if they haven't been assessed, but just to have an appreciation of the types of movements that need to be incorporated. So big movements, powerful movements, movements that have large amplitude. Frequently, I see people who don't position themselves properly in front of a piece of furniture, so a chair or a bed, when they are going to sit down. They misjudge the distance and frequently sit on the armrest, or unfortunately, I've seen people sit on the floor. And this, of course, again, a fall risk. And it has to do with, again, the brain's ability to perceive where their body is in relation to the chair. So there's a square of tape in front of the chair in the video here that I'm going to show that I just put out with some painter's tape. And it's to give people a visual cue about where they need to put their feet and have their feet in the box before they turn to sit down. And it can be helpful. So just having someone practice this to learn, oh, that's the visual target. I need to have my feet in there before I start to sit down. And again, so this is, again, same thing. I just did a turning box on the floor. So we're practicing sitting down safely. This is a video, again, working on stepping. So I tell people, if you're turning right, think about your right foot as the turn signal and the right foot goes first. If you're going left, think about your left foot as your left foot's the turn signal and you're going left, because what can happen is people say, for instance, want to go right, but they actually move their left foot first and cross over, and then they can end up having a fall. So again, this is just different stepping practice. And, you know, Wally continues to work on various forms of exercise. He did a lot of stepping sequences and practices with me. He does boxing. He's learned Tai Chi to help improve his balance. He'll ride a stationary bike. Exercise is very much a part of his life. It doesn't mean Wally never freezes. He absolutely still has freezing episodes, but the overarching goal is to not have falls and to decrease that fall risk. So that's what people really need to keep in mind as well. I'm going to quickly mention floor transfers. Everyone should practice getting up and down from the floor. It can sound really daunting and scary for some, but it's certainly something I practice with people, and I encourage them to practice regularly if possible. It's a practical thing to do, and certainly if someone has fallen and is not seriously injured, and if they have practiced getting up from the floor, it can be a less frightening experience. So whether or not you have PD, please practice this. Just quickly, in terms of thinking about, you know, assistive devices and equipment that might keep you more safe in your home, don't hesitate to install a grab bar if you find yourself grabbing for the towel bar, because you should not be holding the towel bar. If you need a seat for your shower or your tub, a detachable shower head can make things easier. Some people have armrests over their toilet. The bathroom is a really unforgiving place to have falls, obviously due to the hard surfaces. So please, like I say, don't hesitate to make changes if you find yourself reaching for supports. In the bedroom, you know, adequate lighting if you're getting up through the night, the bed at the right height. I frequently see beds that are much too high for people and they're struggling to get into them and out of them, and have unfortunately, you know, wound up on the floor because they're sliding off the edge because it was just too high. If you're finding you're needing to sit down when, you know, say you're putting your pants on, obviously using the bed or having a chair, because if you're finding it's difficult to balance on one foot, it's better to just sit. It doesn't mean that we don't practice challenging things in a controlled way, like standing on one foot during an exercise program, but for something like, say, getting dressed, you don't want to risk it, because again, right there, that's like multitasking. So if you are trying to stand on one foot and get yourself dressed and your brain is having to focus on trying to keep your balance plus put your pants on. So again, trying to simplify situations. So, actively trying to prevent falls frequently means introducing change to one's daily life. It can be tough. It can be really hard for people to try new things and change routines, but in the end, it will be well worth your time, effort, and investment. So my take-home messages for, kind of decreasing fall risk would be, if you've had a fall, address the first fall to prevent the second by working with your team. And maybe that's checking in with your physician, if you see a nurse practitioner, physio, pharmacist, occupational therapist, but work with your team, because addressing, again, the first fall can be of huge benefit to not have any subsequent ones. Move frequently, exercise daily, avoid multitasking when possible, and make adjustments to your home. Use a walking aid as necessary, or perhaps if one has been recommended, kind of pursue that. And thank you very much for having me speak today. And I look forward to your questions if there are any. Thanks.